Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Oshinsky of RWJBarnabas Health Medical Group. As many as 1 in 3 women are affected by gynecologic and bladder conditions that impair their comfort and quality of life. During today's show, we will learn more about urogynecology and pelvic floor disorders, treatment options, and available prevention strategies. We are pleased to welcome Dr. Kate Shapiro, a urologist and specialist in female pelvic medicine and reconstructive surgery with RWJBarnabas Health Medical Group and Robert Wood Johnson University Hospital, Somerset, and Dr. Shirly Solouki, a female pelvic medicine specialist and reconstructive surgeon with Rutgers Robert Wood Johnson Medical School, Robert Wood Johnson University Hospital in New Brunswick, and Robert Wood Johnson University Hospital, Somerset. Welcome to the show. Welcome to the show, both of you. First, for the audience, can you both give us a little bit about background about yourself? We'll start with Dr. Kate Shapiro. Tell us a little bit about your background, where you're from, where you went to med school, and what made you come over to RWJBarnabas Health.
Well, first of all, thank you so much for this opportunity. This is a topic that I feel very passionate about. And I feel very passionate that women understand all of their options available to them when it comes to these conditions that we're going to talk about. I grew up in Dallas, Texas. I then completed my medical school at University of Maryland, and then did a urology residency at University of Pittsburgh Medical Center. And during my residency, I developed an interest in women's health and specifically women's urologic disorders. I then went on to complete my fellowship in female pelvic medicine and reconstructive surgery at New York University, and I'll be starting at RWJ Somerset Hospital this fall, and I'm very excited to establish a practice there. I ended up essentially in New Jersey due to family factors. My husband is from the area, and my family's now in Maryland, so this was a great location for us, and we're very excited to be here.
Thank you. And Dr. Shirly Solouki, can you tell us a little bit about yourself?
Sure, yeah, thanks again for the opportunity. So I'm actually originally from Israel, somehow ended up in the States in 2001, and then went to, did my residency at Lenox Hill in Manhattan, and did, the residency was in OBGYN, and then proceeded with doing a female pelvic medicine reconstructive surgery fellowship. It's a 3-year fellowship at Montefiore, and I was lucky enough to work with both urology and gynecology trained surgeons, which was incredible. And actually due to similar factors, ended up in New Jersey. That's where my husband is from, and had a great opportunity through Rutgers Health, and started there at 2020, and now establishing a presence in Somerset as well. So,
first, thank you both for being urogynecologists. It's a term that we hadn't even had in existence up until 10 years ago. Basically, when a woman would come in with a pelvic floor condition, I had no options other than telling them to do Kegel exercises. And if I sent them to a urologist, the urologist was doing cystoscopies and looking for urinary things and not combining the two elements of the women's pelvic floor. So tell us a little bit about the common pelvic floor. Tell us, first of all, what the pelvic floor is in a woman, and then what the common conditions are that need a urogynecologist.
Sure, yeah. So the pelvic floor is really... It's a combination of muscles and tissue that you have essentially holding several vital organs that exist in your pelvis and your abdomen in place. So it consists of muscles, and the organs that it's supposed to really support include your vagina, your bladder, your rectum, your small intestines, the urethra. Those are some of the organs that are supposed to be held in place. And essentially, what may happen due to kind of wear and tear, so age, and also just a genetic predisposition. So just the quality of your tissue is something that's, essentially genetic, and certain life events like being pregnant and giving birth, having forceps deliveries or vacuum deliveries, and all sorts of other chronic traumas, which could be as the result of being very overweight or doing really heavy lifting at the gym. Or lifting really heavy things because you work at Amazon, or in a job that requires you to do a lot of heavy lifting. All of that wear and tear can eventually harm and damage the pelvic floor and the structures that I just described, including the vagina, bladder, etc., are no longer well supported, and that can lead to some symptoms and some conditions.
That was a beautiful description of the pelvic floor. And just to kind of hone in on a couple of the most kind of common pathologies that we see, one of the most common is female urinary incontinence. And there's really two types of incontinence that we see most commonly. The first one is overactive bladder, where the bladder is squeezing too much. It's squeezing when it's not supposed to. And there are a lot of options for treatments for these patients. There's behavioral modifications, there's medications, and there's also procedures. The other type of incontinence is stress urinary incontinence, where there's a weakness around the urethra or the urethral ligaments, and treatments for that really focus on strengthening the urethra, and those can be behavioral as well as surgical. And another pathology that we see a lot is pelvic organ prolapse, which, as Dr. Solouki had said, with childbearing, obesity, chronic smokers, chronic cough, or lifting lots of things start to descend and start to fall into the vagina, and patients may describe a bulge or a ball coming out of the vagina. And there's also lots of options that I know we'll go into for treatment of that.
Also, it's the age of the patient, because after a woman goes through menopause, things also change within the uterus and pelvic organs.
Absolutely. And that was another thing with menopause becoming there's more attention on menopause now. And there are lots of things we can do for these patients. A lot of these patients before, during, and after menopause will experience urinary symptoms or vaginal dryness. And there are simple solutions for this that not many providers are so comfortable with, but that we're trying to kind of educate a lot of providers, because it's something that sometimes can be an easy fix and can make patients feel a lot better.
If most of the time I'm getting the woman who is postmenopausal, either having the overactive bladder, she's playing tennis and she has to wear a diaper, or I've got the woman who basically just feels uncomfortable during sexual encounters. And these are the perfect women to refer to the urogynecologist. So if I do refer them, what do you exactly do?
You have to tailor the treatment to the type of patient. So after a thorough assessment, which includes taking a history of the patient, really identifying and listening to the patient about what is it that's bothering you. Because I could see many things on the physical exam, but they're not necessarily bothering the patient. And then you do a physical exam and try and really pair the two and identify what is it that the patient really needs. So in general, I think nowadays there's really like a few lines of treatment. Usually there's like a first line, which is lifestyle changes. The second line, which typically would be a medication. And the third line, which could be a surgical treatment, depending on what the condition is. So sometimes it could be a simple intervention, such as telling the patient not to try and avoid things like bladder irritants, which could make you go to the bathroom more often, or doing pelvic floor physical therapy, which is essentially doing pelvic exercises in a supervised manner with a pelvic floor physical therapist. Or it could be something as simple as using a vaginal estrogen cream. and educating the patient on how to use it. Sometimes it could be a simple intervention like that, and sometimes it may require something a little bit less conservative. But I think generally nowadays, most providers try and start with more conservative management and really reserving the more invasive management for patients who fail the first and second line treatments.
And one of the other things that is, I think, very unique to our field is that a lot of this is not life-threatening. This is quality of life that we see. These surgeries can be elective. So really, it's honing down how bothered these patients are and how aggressive they want to be. We have all sorts of things that we can offer, but if they don't want to do something aggressive, we can start very conservative. So really, when patients come to see us, we really want to get from the patient how bothered and how much this is affecting their life, and that determines how aggressive we can be with them.
And as you know, unfortunately, this isn't in the newspapers, magazines, the way heart disease is, diabetes is. So when they come into a primary care office, one, it's sometimes hard to get out the real reason why they're there, that they are having incontinence, and that's actually what is bothering them. Unfortunately, in many of the diseases of the females, that society just doesn't recognize that there is a difference between a male and a female, and that there's a lot of things that really do need to be treated, and sometimes more aggressively, but because of the way lifestyles are, they don't bring it up.
That's absolutely true, and that is something where I feel like us as clinicians, and also there is more attention in media being focused on this, but definitely not enough. And, postpartum issues and menopausal issues, these are things that I think it's kind of on us to try and elicit whether the patient's really bothered by that, because patients are so embarrassed by these conditions.
I think you make such a good point in terms of these topics are taboo. So patients, women, and even men probably, right? The chances are they're not going to feel comfortable disclosing to a relative, a friend, whoever it is, the physician, that, hey, I'm experiencing leakage of urine, or I'm feeling like there's a bulge coming out, right? Women don't talk about it, maybe because it's not sexy, or maybe because there's something about it that's just, embarrassing. And I think part of the issue is that there's just not enough awareness. There's not enough awareness that prolapse happens until it happens to you, because people don't really talk about a bulge coming out through the vagina, right? And even amongst physicians, it's no guarantee that a physician is going to be aware of this condition called prolapse unless you have seen it or maybe got exposed to it in your OBGYN rotation. It's not necessarily something that's going to be covered in your medical school curriculum. So I think that's another issue that needs to be tackled with providers, especially primary care physicians, that this condition exists. What are the risk factors? What are the symptoms, manifestations, so that they're aware and they know who to refer if that really occurs. So I think there's a lot of work that needs to be done in terms of just education, making people, both providers and patients, aware, and normalizing the conversation about it, that it's not taboo, and that, it's completely okay to talk about it, and that they don't have to suffer silently, that, things can be done. So we definitely have our work cut out for us, but we definitely could use our primary care colleagues, because there's not many of us urogynecologists. There's only so much that we can do. So I think it's going to have to be a kind of a widespread effort.
So what would you advise a primary care physician?
So I really want to stress the benefit that patients can have from pelvic floor physical therapy. That's one thing where I think primary care can really be educated on the benefits of that, because there's different types of pelvic floor physical therapy. There are physical therapy exercises to strengthen the muscles of the pelvic floor, and there's also physical therapy to relax the muscles of the pelvic floor in patients who may have chronic pelvic pain. It's a wonderful modality for that. It's also great for urge suppression techniques for women with overactive bladder, who we try and essentially teach them to try and hold off on going to the bathroom so that they can lengthen the interval between how many times they're going. So there's lots of uses for pelvic floor physical therapy, and I think that that's a great first step for a lot of the conditions that we see. And that's something that primary care physicians can easily prescribe to patients. They just need to know, and we need to help educate where these pelvic floor physical therapists are, because they are physical therapists specifically trained in pelvic floor. It's not just someone who's going to help with like orthopedic injuries or recovery after an orthopedic surgery. So it needs to be a specialized pelvic floor physical therapist. And then kind of the next thing I would try to educate for primary care is medication use for overactive bladder. There are many medications on the market, and there's really two classes that are commonly used. And these work to kind of calm down the bladder. And we usually do a 4 to 8 week trial for these. And we either try 1 or 2 or 3 medications sometimes. And if patients are failing that and they're not seeing improvement, then is the time for the referral. And we talk about maybe bladder Botox injections or other surgeries or procedures that might benefit them.
So again, the important thing is, 1, consideration of pelvic floor physical therapy. At the medical school, I know that there are some physical therapists who are trained in it, and therefore it's important to send them to a place such as Rutgers Medical Center, where they do have the specific physical therapists who deal with pelvic floor disorders. Number 2 is with the incontinence. As a primary care physician, yes, after I get the woman to actually open up, I may try Detrol, I may try Ditropan, I may try Myrbetriq, I may try Vesicare. The problem, of course, being the side effects of it. And that sometimes limits their ability to be used. I'll send them to the OBGYN, where they'll have a thorough pelvic exam, and maybe the use of estrogen creams may be helpful also. But the problem is then what to do after that. And that's why I'm thrilled that we have the two of you to be able to refer to. So I've got someone who's failed that. I send them to you. Tell me what's the next steps. Tell me also, if it goes to the point of surgery, tell me a little bit about the robotic surgery that you guys do.
Sure. So I'll be happy to discuss some of that. And I'll even backtrack and answer the prior question, or complement the answer. I think some of the barriers to care with our patients is really identifying the patient. So sometimes a simple intervention, like giving a patient a questionnaire on pelvic and urinary symptoms, it's just like an 8-item questionnaire, could identify some of these patients and have them open up. Like it's something you can give them in the waiting room if it's a new patient, or over a certain age, or if, as part of your annual care. So that could be one way to really identify those patients and get them to discuss that issue. Another resource that the urogynecologist will be happy to share with you, there's no need to reinvent the wheel, is really a list of those pelvic floor physical centers, pelvic floor PT centers that we refer to. That could be another barrier, is like, where do you find someone like that? Well, we have lists and lists of these centers that we'll be more than happy to share with a primary care physician. So those could be 2 simple interventions that we implement in our office that could be easily implemented in a primary care setting. In terms of the third line treatment, so it really varies, depends on the condition. So if we're talking more about overactive bladder, the pathology there, the problem there is really with the muscle nerves, with the muscle and nerves of the bladder. So after you really tried your first and second line treatments, which would be lifestyle changes, a little bit of estrogen cream, medications which could relax the muscle of the bladder, you're talking about third line treatments, which are procedures. So one procedure which can target the bladder muscle is injecting Botox. Just like you inject it in the face to paralyze some of those muscles to make you look a little bit younger, you can do that into the bladder. And it can either be an office procedure, depending on the office and whether that's available, or it can be a same-day procedure in an ambulatory center under sedation. And typically the Botox starts kicking in about 2 weeks after the injection, and it can last anywhere from 3 to 9 months. So typically has to be repeated once or twice a year. The other procedure that can be done targets mostly the nerves. It's called sacral neuromodulation. and essentially consists of placing a little electrode in the S3 foramen, so that's located in the lower back, and it gets powered by a tiny little battery. It's the size of a USB drive, like maybe half my finger. It's very small. That's placed under the skin. So it's a little bit hard to explain that technology, but sometimes I explain it like it's like almost like a little bladder pacemaker that helps reduce the frequency of urination and also those urgency-related incontinence episodes. So we definitely have some excellent treatments that are available for patients. Those are just some of them.
Yeah, the only other third line option is acupuncture therapy, actually. And the only reason that it's really considered third line is because it's pretty time intensive. It does require multiple visits to the office for stimulation actually of a nerve in the ankle. And it's 12 30-minute sessions, so once a week for 12 weeks. And there's really no risk to it. It's just that the patient has to come to the office to get it done. There are studies out there looking at maybe an implant into the ankle so that the patient can do these sessions at home, but that's not approved yet. But those are the third line options that we have, and they work very well.
And now robotic.
One of my favorite words. So robotics really comes into play with pelvic organ prolapse. When it comes to pelvic organ prolapse, we're going to shift gears. We can talk about treatments for pelvic organ prolapse. Those range from conservative to surgical therapies. When a patient comes in with pelvic organ prolapse, it's really important to elicit the bother. Once again, this is not a life-threatening condition, but really a quality of life. So how bothered is the patient by this? Sometimes you don't need to do anything for the patient and they can just live with the prolapse. One option for the patient is, once again, pelvic floor physical therapy. This has really been shown to be great for patients who have descent, maybe to the level of the vaginal opening or the introitus, or maybe a little bit above. For when women have descent really outside of the vaginal opening, pelvic floor physical therapy may not be as beneficial, but it's still a great option to start with. The second therapy we can offer them is something called a pessary device. And this is a silicone device that's inserted into the vagina to push everything back up. It's kind of like a bra. It doesn't fix the problem, but it does provide comfort and relief to the patient. There's all different sizes and all different shapes. They can stay in for weeks to months at a time. And they can be a really nice option for patients who don't want to take the next step, which is usually a surgery. And when it comes to surgeries, there are multiple different types, one of which is robotic. And that is usually a surgery where you're implanting mesh to help pull everything back up. And it's important to know, for patients to know, that the mesh that's used in this surgery is not the mesh that was taken off the market or recalled about a decade ago. That was a different mesh that was used. This mesh has been studied over many decades and has been shown to be very safe and effective for patients. It's a very good repair to pull everything back up. And also, one of the benefits of this surgery is that it allows patients to have penetrative intercourse afterwards, because there are some prolapse repairs where actually patients cannot have intercourse afterwards. So it's important to really tease out from the patient how active they are, and if they want to maintain sexual activity after the surgery.
Great answer. And if we backtrack a little bit, one of the fun things about being a urogynecologist, or one of the more stimulating aspects of it, is also the surgery, right? You gotta love surgery to do urogynecologgy. You have to be familiar with a complex anatomy of the pelvic floor. You're diving into some deep layers in there. And one of the things that I enjoy the most about my residency and also fellowship training is the fact that you train in abdominal surgery, which is laparoscopic and robotic. Sometimes it's even larger incisions, or vaginal surgery as well. It's really cool because you can take out a uterus vaginally with no incisions to the abdomen, and really very quick recovery for the patient, especially in instances where the uterus is essentially coming out vaginally, you may as well just take it out that way. But still, there's a huge role for robotic surgery. So sometimes a robotic surgery, which is done abdominally, may be a better fit and more appropriate for a patient. So I'll give you an example. So first of all, robotic surgery is just a more advanced laparoscopic surgery. So laparoscopic surgery is when you make small incisions in the abdomen. Typically, it involves 3 to 4 or 5 incisions. One is going to be at the belly button, where you insert your camera through, and then the other incisions is how you insert your other instruments. And where the robotic surgery kicks in is that the robot connects to those devices that you're using. And the surgeon does not rely on assistance as much to operate those devices. You actually have control of most, if not all, of the ports and the incisions that you made. So that is one of the advantages, is that you have pretty good control of or essentially ultimate control of those instruments. The other advantage is that you have really excellent visualization. You're able to kind of get a close-up. You have a 3D visualization, which you don't get with traditional laparoscopy. And lastly, with the robot, you're actually able to articulate your instrument, meaning you're able to kind of move it in almost a 360 motion. So it's really good if you need to separate very delicate tissues, or if you have a lot of suturing and knot tying to do, which we can have when we're doing reconstructive surgery, for example, for prolapse. So robotic surgery has really advanced our ability to do very complex surgery and dissection. It saves us time, and we can even do nearly a better job at it because we have better instruments. So where robotic surgery is really relevant in urogynecology is one procedure, for example, is a sacrocolpopexy, which is what Dr. Shapiro was talking about. A sacrocolpopexy is kind of a complex term for attaching the vaginal wall or the vagina. That's what the colpo refers to. And you essentially attach it to a ligament over your sacrum. And in order to bridge the two, there's a distance between the two. You have to use a piece of mesh. And the reason that we use mesh is because the person's tissue is not great to begin with. That's why they got prolapse. So just, for the same reasons that you need to use a mesh for hernia repair, like the general surgeons do, sometimes we also need to use mesh in our surgeries in order to complement and give a little bit more strength to the tissue, which is predisposed to weakness. When we don't use mesh in our surgeries, the recurrence of prolapse can be higher. So that's really the benefit of using mesh. And like Dr. Shapiro said, it's in a very safe manner. You're kind of essentially placing it over the vagina and over the cervix. You have it's much safer when it's done that way abdominally. And in a sacrocolpopexy, it's pretty much a gold standard for treatment of prolapse patients. One of the most effective treatments. There's a lot of suturing and knot tying that needs to be done. So that's why it's such an excellent procedure to be done robotically, because again, you have that articulation and it's very easy to tie the mesh to the vagina, but definitely can be done laparoscopically. I've trained in both without the help of a robot, and it's both are an option. But I would say more and more urogynecologists are using it robotically, or doing it robotically nowadays.
Both of you, any key messages before we sign off?
Just to keep this on your radar for providers to really think about these issues when it comes to menopausal women or postpartum issues. In other countries around the world, pelvic floor physical therapy is implemented postpartum right away, and that's not something that we've adopted here. So just kind of keeping these issues in mind, because the patient will not always bring these up. And we have providers that can help with this. We're a growing field. We realize the need for our specialty across the country. So take advantage of us.
Dr. Solouki, any last words?
I think with just a lot of work that needs to be done in terms of awareness, education of patients and providers alike. Definitely use your OBGYNs and urogynecologists and urologists as your resource to get those more advanced treatments for your patients. And really just keep in mind that the treatment is not going to be surgery right away necessarily, right? It's just there are more conservative management that we can offer to our patients. But the good thing about the medications and the surgical treatments is that it means that there's just more options for the patients, and they're great options. So I think people don't need to suffer silently. Definitely talk to your primary care physician about those issues, to your OBGYN, your urologist, and they'll refer you to the proper location.
Thank you both for being here. Thank you for all you do for our patients at RWJBarnabas Health.
Thank you for the opportunity. Absolute pleasure.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. For more information about women's health services at RWJBarnabas Health, please visit us at www.rwjbh.org/women's health.